All right. Well, that was my cue that it is 12 o'clock on the dot. Um, just so everyone knows, we will be recording today's session so that we can post it up on the website for those that were unable to attend today to view it. I want to welcome you all on the 23rd of February. I don't know about other states, but today in Massachusetts and some of the other New England states, we got a little bit of snow. So nice, lushy, cold weather. Winter is still here, and it was letting us know. So let's go ahead and get started. My name is Stephanie Baker. I'm with Health Centric Advisors, part of the iPro QIN-QIO. And today I'm joined by Karen D'Antonio, who will be monitoring our chat for us. Can you hear me okay? Perfect. So just a quick refresher on who we are. The iPro QIN-QIO is a federally funded Medicare Quality Innovation Network quality improvement organization. We have there are 12 regional CMS QINs QIOs nationally, and iPro represents New York, New Jersey, and Ohio. We have the New England states, and Clarendon at Maryland, Delaware, and the District of Columbia. We work with 20% of the nation's Medicare fee-for-service beneficiaries. We want to make sure that our session is as interactive as possible. So please definitely utilize the chat throughout today. You can chat in any questions as you think about them. You can also comment on anything that you might be doing as far as, working with your multi-visit patients. This has been a series of events, so we want to hear from you, and we're trying to make this as much of a sharing experience as we can. So just to get you warmed up and ready to chat in, please let us know who's on the webinar and what organization you're calling with, where you're located, and what your role is within your organization around managing your multi-visit patients. We have a jam-packed session today. We will be hearing from Brendan Hayden shortly on mobile integrated healthcare. And then we're going to follow that up with some questions. And then we're going to do a series wrap up. As I mentioned, this has been going on. We actually started this series in November, and this is our final series for this session. And then we'll follow up with some resources and then open it up for even more discussion. And as I said, we have a lot to get through, so I want to hand it over to our speaker today. Today we have Brendan, who is the Vice President of Mobile Health Services. Brendan has an impressive background in EMS and healthcare industries with organizations such as Steward Healthcare System, South Coast Health, and several EMS agencies throughout southeastern Massachusetts. He has strong analytical and program development skills, and he excels at building and implementing large strategic initiatives. So with that, I'll hand it over to you, Brendan.
Thank you, Stephanie. It's a pleasure to be here today from a very snowy Boston, Massachusetts. It's finally starting to end. I know I am one of very many states who are getting snow today across the country. We only got a couple inches of slush up here, so we consider ourselves very lucky. So it is a pleasure to be here with you today. As Stephanie said, my name is Brendan Hayden. I'm a 33 or 34-year plus paramedic who's worked in healthcare management, hospital management, health system management in a large, multi-hospital system that is international based and US based. And now I am fortunate enough to be working for Cataldo Ambulance in their SmartCare division, which is their mobile integrated healthcare division. So to start off with, mobile integrated health is really the use of pre-hospital care providers or paramedics in a very different format. So the traditional EMS model or emergency medical services model is that paramedics or EMTs respond to a call, they assess a patient, they begin to treat them, and they take them to the hospital. Probably about 60% of the calls that EMS responds to are patients that really don't need ambulances or patients that could be safely managed at home. And back in the 1990s, believe it or not, in the early 1990s, the birth of MIH took place in Red River, New Mexico. And that was the use of paramedics to care for patients on Indian reservations in remote areas. So you would have a paramedic that staffed a clinic who was also responsible for ambulance care on the reservation. who would be connected via telemedicine with a physician who could assess patients and manage patients, and the paramedic became the telepresenter and was basically implemented the treatment on behalf of the physician. So that program was in place for a couple of years, and believe it or not, it failed. And the reason it failed is because it didn't have key infrastructure in place to be able to support patients. So we've learned a lot from then, and mobile integrated health has really become a hot button issue in this country, certainly in the EMS industry, in the home care industry, and in many other industries, especially with the advent of home hospital initiatives. Next slide, please. So kind of the timeline for us is in 2007, the IHI came out with its triple aim focus that basically said, let's optimize performance, let's reduce cost, and find a way to improve patient care. And this is really important because any type of mobile integrated health program that's put in place needs to, basically provide a high level of care, and it needs to reduce costs. There are a lot of MIH programs that are out there that basically are kind of bootstrap financed and are basically in place to serve the community at the expense of the community. That doesn't reduce costs. And the key here is that an effective MIH program has to sustain itself, and it has to, of course, click all the buttons on patient care and reduce costs. Really important. In 2010, the Affordable Care Act said, hey, there has to be a way to reduce costs by encouraging healthcare providers to get in touch with other models and look for other ways to better coordinate care. I think, based on the list of folks that are on this call, we all recognize how fractionized care is and how much worse it was back in 2010. And to some extent, it's gotten better. We're really focused on coordinating a bit better. In 2014, here at Cataldo Ambulance, we began building our first MIH program. And again, Cataldo really is an ambulance company in every sense of the word. Started in 1977 with 2 ambulances, now has over 100 ambulances and multiple divisions, and is the largest 911 provider of communities, 19 different cities and towns here in Massachusetts. So we started on the 911 side, and Dennis Cataldo, who owns the company and is the family name that started the company, recognized that this MIH served as an opportunity to better get in touch with our communities and be able to better manage patients that didn't necessarily need to come to the hospital. In 2018, the state of Massachusetts funded an MIH program. And what that was is they funded the development of regulations that would allow for the provision of care through a mobile integrated health program here in the Commonwealth. Those regulations came out, and we, Cataldo, in 2019, not only assisted in building the regulations, but was the very first licensed mobile integrated health service in Massachusetts. Today, we have over 12 units that are staffed every single day. They're non-ambulances. You'll see a picture of the vehicles in just a minute, that are staffed with EMTs and paramedics that have responded to thousands of calls since 2019 for multiple key partners. Next slide, please. So this is just a quick look at our partners, some of our key partnerships out in the community. 2 notable companies, Instead, which is really a home care company, fantastic company, and Medically Home, which you may have heard of before, which does a lot of home management, some home hospital stuff, and others. And we work with other key players in not just straight mobile integrated health, but we also work with hospice, we work with palliative care, we work with VNA. We work with specific physicians' practices. We work with skilled nursing facilities and long-term care facilities to be able to manage patients. Dr. Goldberg, Scott Goldberg, who is an emergency physician at Brigham and Women's Hospital, is board certified in emergency medicine and EMS, is our medical director, and has been a huge talent for us in helping to grow this program. Very, very innovative physician leader, and we're very lucky to have him. Next slide, please. So just a quick look at our coverage, and I call this little SmartCare B picture. You get all these little vans flying around the state, but each one of these vans is equipped with either an EMT, depending on the need, or a paramedic. Most of them are paramedic staff. And within that vehicle, that paramedic, that SmartCare paramedic, who has been through about an additional 300 hours of training and skills verifications and certification to a national standard, that paramedic is basically able to take urgent care medicine plus, if you will, to the patient's home. And through key partnerships, we are responding to 50, 60, 70 calls a day throughout the state to be able to manage patients. So it's got the traditional paramedic equipment inside of it, EKG monitors, telecommunications stuff, medication, so on and so forth. And then it really has expanded scope skills, the ability to access a PICC line, the ability to do straight caths and Foley caths, the ability to carry antibiotics. We carry multiple antibiotics on the vehicles, antiemetics, other type medications that are better focused on managing patients in their acute time of need with the focus of safely keeping them at home. This also goes to say here that we also do cover Rhode Island and will soon be in New Hampshire as well with the SmartCare program. So it is a program that is expanding as time goes on here. Next slide, please. So as I said before, kind of equipped for urgent care plus, but there's lots of different uses for mobile integrated healthcare in the community. You know, the first, of course, is to reduce costs associated with frequent 911 usage. So ED aversion for frequent flyers. And this is a great way because a lot of patients that call 911 need assurance and contact and some minimal treatments to be able to get them healthy, keep them well, and keep them out of the hospital, with then follow-ups with their PCPs or others the next day. It's increased ED avoidance for non-emergent calls that never should have come in through the 911 system, that call 911 because the patient has no other access point to the healthcare system at that point because of mobility issues or home issues, socioeconomic issues, so on and so forth. Improve patient outcomes for chronic conditions. We care for a host and variety of chronically ill patients that have chronic COPD, chronic CHF, where proactive medicine in the home will prevent that trip to the hospital. I say all the time that 911, the activation of the 911 system is reactive medicine. The use of mobile integrated healthcare is proactive medicine. And that's all with the focus of keeping patients out of the emergency departments and out of the hospital whenever possible. Of course, you can use MIH to support readmission programs on patients that are discharged in that 30-day readmission window. MIH providers will touch them at home a certain amount of time over the course of their home stay to help reduce this recidivism back into the hospital and the burden that carries for the healthcare system. Of course, earlier discharging using in-home visits. You know, we are part of a couple different hospital at home programs, CMS funded hospital at home programs, where we provide nights and coverage and episodic coverage to those programs, in addition to a very talented nursing team that manages these patients at home. Increase patient satisfaction and peace of mind. I got to tell you, as a paramedic, I've never seen so many positive responses on care and feedback from families, physicians, and patients as I have since we've been in the MIH space. You know, the gunshot wounds and stabbings and really bad car accidents don't always say thank you, but the patient that you give some Zofran and a liter of fluid to at home, and you do some point of care testing on them to make sure that they don't have COVID and their CBC looks good, they'll love you forever by keeping them home and not having them wait in the hallway of a hospital. And of course, improved patient outcomes and compliance. And that is really the entire focus of why we're running a program like this. Next slide, please. So who benefits from mobile integrated healthcare? Next slide, please. So there are some direct benefits, beneficiaries, if you will, physicians groups. And you know, think of this with the picture of who are your MSSP patients, your Medicare Shared Savings Programs patients? Who are your Medicare Advantage patients? Who are patients who might be part of the state-funded Medicaid program that need extra coverage or access issues? And you can start to overlay where the need is and who the direct beneficiaries are. So physicians groups, urgent care alternatives, after hours coverage for their patients. You know, many of these docs, as you know, are under risk arrangements with their insurance companies or CMS, and being able to manage the patients, the doc who gets the call to say, I'm going to send our SmartCare team out to check you out, and they can talk with me and we can decide what the best course of treatment is for you at that point. VNAs and hospice. You know, I thought getting into this business that our partners in the Visiting Nurses Association, hospice palliative care, would be, you know, really standoffish about the use of paramedics in this setting. But come to find out, they're very welcoming. We are covering nights and weekends for many VNAs and hospices as part of our program. And it's been a great partnership where we work really well together. Of course, home hospital programs, which I mentioned, ESP and PACE patients, again, kind of risk-based patients. Long-term patients in skilled nursing facilities, I'm sure as many of the participants on the call know today, there is a variety of different skill competencies across the SNF and long-term care facility spectrum. And having the ability to have a SmartCare provider come in and work with the nursing team in a nursing home with IV antibiotics, PICC line access, and all the other things that we do, point of care testing is really important, and it really works well in keeping patients in the facilities and not having to send them out to the hospitals. Assisted livings and municipalities, we've done 1 million vaccine testing here in Massachusetts. We're the largest purveyor, if you will, of state-funded vaccine testing administration here in the Commonwealth of Massachusetts. And then the patients, significant benefits, right? So on demand, after hours, don't have to leave your house. The chronic illness management, so it's the CHFer that, you're recognizing that they've gained 3 pounds in a couple days, and you're going to get proactively ahead of that and adjust that Lasix dosage before they move to crisis and end up, in reactive medicine in that trip to the emergency department with a 3 or 4 day admission. ED alternatives, of course, for the high 911 utilizers, the post-hospitalization follow-ups, and on and on and on, many of the things I just mentioned. Next slide, please. So how does it work? Next slide, please. It's actually pretty straightforward, right? So the partner process is really a 3-step process. Number one is a partnership is established that identifies who are we going to use as the physician that we're going to interact with. Every single mobile integrated health call touches a provider, whether that be a physician, a nurse practitioner, a PA operating under a physician. There is always physician interaction or mid-level interaction in our encounters that we have with patients. That's really important because they're really not our patients initially, right? These patients belong to the physician's practices, the skilled nursing facility, whatever the medium is that we're managing, hospice, palliative care. And it's important that the physician or provider who manages that patient has touch with what we're doing. So we become the telepresenter in that situation. The physician guides the care and directs the care at that point. Second step, specially trained SmartCare paramedics and EMTs operate through a fully staffed and manned 24/7 dispatch center that will then respond out to the patient's home at the time of request. And I will tell you the requests typically come in from those partners that you saw on the last slide. That could be the physicians, the SNFs, so on and so forth. They'll respond out, they provide an evaluation, they provide treatment in consultation, either via telemedicine video, telemedicine phone, with a practitioner, a physician, practitioner, provider, nurse practitioner, so on and so forth, to assess the patient and manage the patient. And then the third step is we have the ability to do labs, diagnostics at the bedside of the patient. That'll integrate back into their record, and we can, of course, manage that patient in that setting. And if the care escalates, we can always, trigger the transport to the local 911 entity that then comes in and takes that patient to the hospital. So it's really important to recognize that this is not just a paramedic going out and caring for someone. This is really part of a much larger continuum of care. Every single patient that's managed through mobile integrated health should be tied back to that primary care physician or specialist for follow-up and reevaluation. Our records flow seamlessly back to our partners that we work with so that none of this becomes fractionalized care. All of this is very well integrated and very well tied together. Next slide, please. So just a quick picture again, starting on your left side of the screen, we received the call from the patient, the non-transporting resource. Again, these are not ambulances. They're, separate kind of like work vans, if you will. We'll respond out and interact with that patient. We'll get the physician on the line after we've done an evaluation on the patient, present the case to the physician, just like you do in an emergency department or on an inpatient unit in the hospital. The physician will say, hey, I'd like to get let's get a Chem 8. I'd like to see what their H&H is, so on and so forth. And we can run those labs in real time. It takes about 10 minutes to run a lab at the patient's bedside with the technology that we use to be able to do that. And it's an iStat, and we have multiple cartridges that we can use depending on what our partner organizations need to manage their patients. Patients managed, decisions are made. Can they stay home? Do they need follow-up care? Do we need to come back in a couple hours and recheck on them? Whatever the situation is. And then that documentation is all sent back to the patient, the physician who owns the patient, if you will, and a patient gets obviously follow-up instructions from us in real time at that time. Next slide, please. So, couple interesting facts here, right? So, what we have learned over time is that our average response time to go out and manage a patient takes 35 minutes for us to get out to the patient's bedside. Unlike the world of 911, our time with that patient is about 75 minutes. Now, I will tell you, we've had encounters that take 30 minutes, and we've had encounters that take 4 hours. And the fact that this provider from SmartCare is dedicated to managing that patient in the home until the decision can be made whether or not they can stay home or whether or not they need to go, to a different level of care, need to go to the hospital, whatever the case is, it gives them the time and latitude to really focus on that patient in that setting. I'll also tell you that when you're running a liter or two of fluid into someone to hydrate them, our SmartCare providers are pretty interactive. They'll do laundry for the patient, they'll wash dishes for them. It really is a complete picture of care to that patient. We grow very close with a lot of the patients we manage. And our results have shown that less than 10% of the evaluations and treatments result in a subsequent transport to the emergency department. And furthermore, when you look past that 1, 2, 3 days, it doesn't show recidivist behavior after those days either. So this truly is managing that episodic issue for that patient, and that's keeping them safe and home in a manner that is, both benefiting the patient and, of course, positively impacting the healthcare system as well. Next slide, please. So the bigger picture, these SmartCare paramedics are not your garden variety providers. I'm very envious of the care that these folks provide. These are very experienced paramedics that have had a number of years experience working in the 911 or into-facility transfer world. They all go through specialized training through a national standard, an AAOS standard, which teaches the Mobile Integrated Health Paramedic Program. And that program really focuses a lot on preventative management of patients. It focuses on labs. It focuses on specific skills and treatments that are, better equipped for the patient's home. I mean, paramedics don't technically learn how to do straight casts. We don't learn how to do Foley casts, but that is something that happens quite a bit, within the role of the SmartCare medic. As I said before, these are non-transporting vehicles, no lights, no sirens. It's really just a very different pace of care that is focused on managing that patient in the moment. If the patient does need to go to the hospital, we always contact the local 911 provider in that community, and we work with them to either transition to care or to ride with them to the hospital. So for instance, if we have antibiotics hanging on that patient, that may not be a skill that those particular paramedics are well versed in, and we will go with them to the hospital to make sure that transition to the emergency department is a safe one for the patient. Once on site, patient assessments performed, information is communicated, physicians are involved, and it all focuses around the patient at that point. Next slide, please. So who pays for the visit, right? So it all, unfortunately, at some point in time comes down to show me the money. And the payers here, next slide, please. The payers here can be a variety of people. So currently in Massachusetts and in most places in the country, mobile integrated health is not recognized by third-party payers. So we are paid directly by our healthcare partners. So there are a hosted litany, as I'm sure all of you know, of different companies that are out there that are focused on working with hospitals, partner organizations to better manage patients. So we're paid by them. So this is actually created, as I'm sure you're all gather, it's created a whole new model of healthcare reimbursement where we're operating outside the world of insurance. I would be more than happy to have the third-party payers step forward and say, hey, we'll cover your services. But today, that's not the reality. I will say that there is a federal trial going on across the country called ET3 that is looking at ways to use mobile integrated health to reduce the cost of healthcare through CMS and improve patient outcomes. So depending on the result of that, there may be down the road some incentives from CMS to be, for CMS to be able to cover the services. As I said, the vast majority of our patients are Medicare, shared savings patients, patients under risk, under some type of risk arrangement. And that really is the sweet spot for us. But when you think about how far out you could extend the use of this type of program or other programs like this, really the sky is the limit if reimbursements come down the road. Today, it's financially sustainable when you work with key partners that are engaged in this. tomorrow it could really change the paradigm of healthcare delivery in the pre-hospital setting. With that, I think that's my last slide, but we'll go to the next slide just in case. I'd be happy to take any questions that any of you may have.
Great. Thank you, Brendan, and very impressive. Just a couple questions, and I'm going to ask folks to please come off mute if you'd like to ask Brendan a question, or please feel free to chat in. But we did have a question from Heather. How does our physician group partner with you? So how is the best way if they want more information about partnering to get in touch with you, or how would that work?
Yeah, sure. So if you just shoot me an email, my email is on the screen there. It's bhayden, B as in boy, Hayden at cataldoambulance.com. Please feel free to shoot me an email, and we can start the dialogue to see if this is a good fit for you. More than happy to answer any questions offline as well through that email address. We're getting the word out, and again, we're in Massachusetts, but we have operations beginning soon in Rhode Island and in New Hampshire, with more expansion plans coming down the road.
That's great. You mentioned that you're available on weekends and evenings. What are the hours that you're able to?
Yeah, so we're staffed 24/7. So we have, obviously our staffing decreases on the overnights, but we typically have 3 vehicles staffed on the overnight that cover Massachusetts and our other partnering states right now. The bulk and the majority of the calls, candidly, happen around 11 a.m. to around 7 p.m. But, we're EMS people, so we've got to be staffed 24/7. And that, candidly, is where a lot of the benefits come to our partners in palliative care and hospice, as well as a lot of our folks that are doing VNA work. Having the ability to have a 24/7 resource out there for any of our nurses on the calls here. We know what the nursing profession looks like right now, and the large shortages that we're experiencing around the country. Having that resource available to cover when you need them has really been a lifesaver for many of their programs.
I bet it has, Brendan. We have another question from Michelle. Do you have to turn many patients away due to being on a call already?
Yeah, it's a great question. So unlike 911, where an average 911 call is like 90 minutes from beginning to end, and that's like dispatch to I'm grabbing graham crackers out of the ED nurse's drawer in the hospital to have a bite to eat. The SmartCare calls can take some time, but we've built the model in such a way where we have redundancies built in for coverage. We also have supervisors that are on the road that when they're not supervising can step up and take calls. So I will say, and because I'm very greedy, I want to take 100% of the calls. We can never take 100% of the calls, but we typically can get to about 95% of the calls in real time. And keep in mind that not every call that comes in, we kind of classify it as red, yellow, green. A red call is you got to be there in like an hour. A yellow call is like, get there within 4 hours. And then a green call is you can get there within 8 hours, because not every call is the same. If you're going out and you're going to straight cat someone and get a urine culture for a PCP's office and do rapid strep, rapid flu, and rapid COVID, that may not be a I need to be there in 35 minutes type of call. But what we do is we will actually receive the call from the physician's office. We'll agree on what category that call falls into. And then we'll call the patient and say, hi, this is Brendan. I'm calling from SmartCare. Your doctor's asked me to come out and take a peek at you. It seems like you're doing pretty well. We're just going to talk to you for a couple minutes on the phone here and see how you're doing. And we'll pick a time over the course of the day today where we can get out to you. So that gives us lots of capacity on the schedule by really managing the patients along with the calls themselves.
That's great. Thank you, Brendan. Stephanie, I do not see any other questions at this time, but again, please continue to chat in if anything comes up. So I'll pass it back to you, Steph.
Great, thank you. Thank you so much, Brendan. That was an amazing presentation, and it's so exciting to see how much progress the mobile integrated healthcare has made since the beginning, and I can't wait to hear more about the expansion. I'm curious too, if folks want to chat in, if in the other states that are in New England area, do you have a mobile integrated healthcare program in your state? And if so, just chat in what it is so that we can let others know what's going on. Did I see any more things in chat before I launch into our wrap-up session
I actually just saw one. Yeah, I saw it. Most of your partnerships with medical practices and acute care hospitals. So we have both. So we have, Atrius is a pretty big medical practice here in Massachusetts that we work with through a partner organization. So that's a big medical practice. We're actually on the verge of signing several smaller medical practices that are now part of MSSP and risk arrangements. But we also work with Mass General Brigham with their home hospital program. So it really spans the, really is right across the spectrum. So anywhere that you have a need to touch a patient in their home in a non-emergent way to help stave that visit is a perfect setting for a mobile integrated health type program.
Awesome. Thank you so much. Yeah, this was great. This is totally in line with everything that we've been talking about in this series. It takes a village really to manage our complex patients. So now we're going to switch gears for the remaining 30 minutes of this session. We want to take a look back at what we've discussed these last few months and how we've brought into focus the work around complex care. I know some of you have been here with us since the beginning, and we appreciate that. And maybe a few have just joined us for the first time today. That's totally fine. We have all the slides and all the presentations up on the website, so you can go back and take a look at them at another date. So our goal for the series was really to bring the focus to complex care. Some of the sessions held were to get back to the basics by defining what complex care is, figuring out what data you should look at to determine who is at high risk for coming back, what is driving them by utilizing screening tools to help get the bigger picture, and to find out what some of the main drivers are for ED utilization and readmissions. This month, we have heard from some amazing organizations that are doing phenomenal work around complex care and working with multi-visit patients. We heard from Frederick's Health Integrated Care Management Team on how they work closely with their primary care practices, involving a multidisciplinary team. We heard from South County Hospital in Rhode Island, who spoke to how they have utilized community healthcare workers in home health and at their hospital to make connections to their community-based organizations. And from New York Queens Hospital, how they discussed their super utilizer program, which was developed as part of the MAX series run by the Department of Health in New York. And finally, again, thank you to Brendan for that amazing presentation on mobile integrated health and how your team sees patients where they are, keeping them out of the hospital. Each of these organizations have developed a plan and integrated processes and interventions to assist in meeting the needs of their multi-visit patients. So today we quickly want to highlight 10 takeaways from the different sessions that we hosted since November, and we'll wrap it up with a conversation around what you took away and what you'd like to hear more about in the future. First, we define complex care. We pulled this definition from the National Center for Complex Care. Oops, so sorry. They define complex care as a person-centered approach that brings together patients, families, community, and healthcare systems to collaboratively improve health outcomes and well-being for people with complex health and social needs. Next, complex care needs to be person-centered. It needs to span across the various sectors, not just within your four walls. It needs to be team-based, including patients and family members. And efforts need to be driven by data. And along with that, all your efforts always need to keep health equity at the forefront of the work and interventions you're putting into place. We have heard multiple times now that it takes a village. It brings together entities across the health ecosystem to address barriers at the individual, community, and system levels. By using these methods, there is a greater ability to care for the population in need. I love this graphic from the National Center for Complex Care's blueprint. It gives a great view of all the entities that need to be a part of the ecosystem, and each of these organizations can play an important role in the work you are doing. This was reinforced by each of the organizations that we had presenting this month. And we heard how you need behavioral health services, pharmacy, home care, access to food, transportation, skilled nursing facilities, and so on. I'm curious to see how many people on the call today have had meetings with your full ecosystem of providers on at least a quarterly basis. If you have, feel free to chat that in. We'd love to hear from you on that piece. We can't stress enough how important data is in identifying who your multi-visit patients are. In a look at the QIO data from 2020, we were able to see that only 4% of the population is driving 55% of readmissions. We also, in the first session, had emphasized how important it is to explore your organization's process, as this will help you have a clear understanding of who's coming back to the hospital, so you can determine clear pathways and how to better care for your patient population. It can help you need to determine who is reviewing this data, when and with whom you are sharing it with. Is it being shared with the quality group, admissions director, case or case managers, care managers, nurse, social workers? Are you sharing it with your stakeholders? That includes your post-acute networks. And what are the main triggers you can use to identify your multi-visit patients? At our first session, we developed a handout for organizations to use to look at their own data, and we are happy to share this out if it is of interest, and we'll post it up on the website as well. Just feel free to chat us in if you'd like this handout. So once you've identified, it's time to assess and screen. So screening tools can help determine what's driving the patient back to the hospital. Is it food or housing instability? Is it substance use disorders, behavioral health diagnosis, chronic disease? And also, how do you address their needs? So when determining what an effective screening tool is, you need to find out what is relevant to your patients. Are there medical needs, social, economic, behavioral needs that you need to address? And also, some organizations may be serving very different communities. There may be advantages to asking questions tailored to a particular population. In one example presented earlier, there was a lot of food insecurity in the community, but it wasn't because patients needed information about food pantries. They needed transportation to get to the pantries and more bus passes. So don't assume because you know the need or that barrier that you know the reason they're not using it. Here's an example of how New York Queens Hospital assesses their patients. It helps them gather information about the big picture, helps to figure out who knows the patient best, who is not involved in the care that needs to be, what the continuity of issues are, and helps them gain insights. Keep in mind, it's important to focus on the whole person. This is a list of screening tools we had also sent out earlier in the series that we'll post up on the site. As I mentioned, multi-visit and complex care patients require a whole person approach to screening, referrals, and connection to the different resources in your area. Health equity. We all are we're all taking a look at health equity. So while not all readmissions are entirely preventable, it's widely understood that a portion of unplanned readmissions could be prevented by addressing a series of barriers patients face prior to, during, after admissions and discharge. Racism is a public health crisis. The system of racism causes racial inequities in the key areas of social determinants of health, in areas such as education, employment, healthcare, housing, and law enforcement, which are all associated with racial health disparities. These areas are structured to advantage the group in power and disadvantage racial and ethnic populations. And the resource on this slide from the Justice Collaborative Institute is a great tool for how to respond. There are also many patient-level factors for predicting hospital readmissions, such as socioeconomic, race, ethnicity, disability, limited English proficiency, and low health literacy. And it's important to know that condition-specific disparities are prominent in hospital readmissions. For example, for CHF, there's higher readmission rates for Black, Hispanic, and foreign-born patients with low English proficiency. During our talk on health equity, we went over a few ways to address closing the readmission gap. You want to collect socio-demographic data, use performance measurement and monitoring to understand barriers to equitable care, use a series of preemptive efforts that span the duration from pre-admission to post-discharge for patients. You want to consider including non-traditional partners like community health workers, navigators, and/or health coaches. Create systems responsive to the needs of diverse populations and address the health-related social needs that put them at continued risk of bouncing back. Reducing readmissions depends on the patient's ability to understand their diagnosis, the care they received, and their discharge instructions. So effective, culturally and logistically appropriate patient-provider communication is key. You want to utilize and connect with your community-based organizations. We heard from HESCO on how there are a number of community-based organizations in each of your communities. It's really important to understand that in the myriad of federally and state-funded programs, there are often many factors that determine program eligibility. These could include age, income, functional impairment level, and living arrangements. And these factors are often very nuanced, so it's not always easy to explain. Many states have at least one type of home and community-based service waiver from CMS, and many states may have some that are targeted to different populations. These will help expand income levels that are allowable under Medicaid and may be targeted at some of the consumers with certain functional impairment levels. We also heard that when you are referring to your community-based organization, you want to provide them with detailed information. For example, if you complete a standardized assessment at your organization, provide those results as part of a referral to the community-based organization. Provide the associated indication or recommendation in your referral. And an example that Cheryl had used is if you state in your referral that the PHQ-9 was completed with a score of 20, include that this indicates severe depression in your referral language. This will help referral staff determine the pathway and the referral priority status. In community-based organizations, the focus may be more related to functional impairments rather than the diagnosis. And care plans may need to be designed around the task the consumer cannot complete independently and cannot be met through other supports. So really pull in your community-based organizations as part of your ecosystem. As we mentioned a couple slides ago, community health workers and navigators play an important role in multiple settings. Frederick Health talked about how community healthcare workers are their frontline public health worker. They have an understanding of the community served, and they can serve as a link between social and health services to facilitate access and assist with goal setting and work alongside the care management team. South County spoke to how they are utilizing community health workers in home health and working directly with patients and families in the community. They help to identify barriers to healthy living, and it also provided those links to the valuable community resources within their area. You need to have a dedicated team and multidisciplinary teams involved. Frederick Health has a whole dedicated multidisciplinary team that consists of care managers who are assigned to primary care providers and practices, care manager assistants. They have clinical pharmacists that do comprehensive medical management, pharmacy technician that works proactively to assist with identifying high-risk patients, following a hospital encounter, integrated behavioral health specialists that provide behavioral health services, including psychosocial assessments and counseling and referrals. And each of these team members collaborate as part of the care management team. At New York Queens, they work with a number of internal and external partners, and this list shows who is involved and how they created those partnerships and the successes that they have seen in working with each of their partners here. Primary care. Primary care plays a very important role in our ecosystem. They can help educate patients on choosing the right level of care and determine what services may be more appropriate. This is also a great example of an educational handout, letting the patients know when they should see their primary care office, or should they go to the urgent care or go to the emergency department. And I know Brendan in his talk a few minutes ago mentioned primary care as being a valuable resource to them in their mobile integrated healthcare work. Care coordination at its best. There needs to be an emphasis on consistent caring relationships throughout the patient journey. This seems to be the catalyst to positive change at the patient level. So here's a great example of comprehensive care pathway for identifying, assessing, and engaging, and linking and designing a plan for return from New York Queens Hospital that they shared last week. So we come back to this graphic of complex care ecosystem. Success is the establishment of multidisciplinary teams who are given the autonomy to develop their processes for identifying, assessing, and engaging these patients meaningfully. Through the establishment of these ongoing supportive relationships, providers are able to develop a deeper understanding of the patient's complexity and really narrow the scope of interventions around social determinants of health, med-rec, behavioral, some recovery supports, housing, etc. That may be better addressed in the unmet and underlying issues. So with that, I wanted to just include some slides as resources and some great interventions to potentially take a closer look for adoption at your organization. And if any of these are interested, definitely reach out to us. So there's the Project Red. We have Interact Tool. We've mentioned the Camden Coalition, we mentioned the canvas. My picture is in the way now. A resource for nursing homes, which is the Interact Tool, which I already just mentioned. We also talked about the Camden Coalition. And then here's a number of resources to look at for health equity. All these links are active on the PowerPoint itself, so you will get that after this presentation, and it will be posted up on the website. So with that, I know that was a lot of information in a very short amount of time, but we really wanted to pull together everything that we've covered in these last few months since November, and to highlight the number of valuable talks that we heard from the different organizations. And now we want to hear from you. First off, do you have any questions? And second, what topics or information would be valuable for you to hear at future events? Karen, was there anything in chat?
If I'm scanning now, I do not see anything in chat at the moment. I did post the complex care event page where you can find all of the slides, recording tools, and resources that you just mentioned.
Great. Anything that you would like to hear in the future that we can pull together for you? And definitely feel free to come off mute if you'd like. And you can feel free to chat this in or chime in after too. What insights have you been able to draw from attending the sessions, and what might be two of your top takeaways? I think one of the things that I can draw from it was just like how it really does take a village, as we said multiple times throughout these presentations. It takes a whole team approach and a lot of communication between those teams. All right, I'm going to move on.
Steph, I do have a question.
Oh, sure, go ahead.
Michelle's asking ideas for new potential lines of business to expand our services. So Michelle, you thinking of anyone has any ideas for new potential lines of business to expand services? I think you're right, Stephanie, when you mentioned it takes a village and the communication is key. And we've heard some great folks along the series that have shared their innovative strategies and approaches. And I appreciate Michelle. Thank you for clarifying. Those were her takeaways for those new potential lines of business to expand our services. And I think that's great. I think learning and sharing from one another is so helpful during these series. So thank you.
I agree. Thank you, Michelle. All right. Any other insights in there before I highlight some upcoming events that we have? So as we know, chronic disease is definitely a driver to readmissions. And so we do have a new series that we're launching on the 28th of February, working to partner beyond COVID-19. Karen, I don't know if you want to say anything more about the series. Sorry for putting you on the spot.
Yeah, no, thank you, Stephanie. We're excited for this new upcoming series. Stephanie just mentioned a chronic disease prevention and management series. I think it takes it to the next step for the complex care. We know many of them have comorbid conditions, and this is just an opportunity to, again, to learn and share with one another. And we're excited on February 28th to have Million Hearts speak along their lines of their tools, resources they have for hypertension and cardiac rehab. So the link is in the chat. So we hope to see all of you at one of our upcoming sessions. Thank you.
Thank you so much. And we have a series going on around class as well, that you can find more information out on our website. We do have a series where we're looking at a pharmacy-based approach to caring for individuals with opioid use disorder. So that will be on the 2nd of March. And if you know a pharmacist, they can get credits for that. So that will be great. And then I think we have the leaders and stakeholders sharing forum on March 2nd as well. So here we'll be talking about supporting staff wellness. So a number of fun educational events coming up. We definitely encourage you to attend, and please don't hesitate to reach out to us with any questions that you might have. And we'll be sure to get all these resources that we mentioned up on the webpage in the next week or so you can view it there. So with that, I won't keep you all. I will let you all go back to your day. And if you're in New England and got snow, or in any of the other states that got snow, please do enjoy it. So thank you all. And thank you all to our great speakers as well that we've had throughout the series.